Hello, everyone. So it's 4 o'clock. Everyone, thank you for joining us today at this nice webinar. I'm Martijn Hogeboom. I'm the Clinical Collaboration Manager of Soteria Medical. We're organizing this webinar today together with our clinical partners, Professor Jelle Barends and Professor Kai Villanova. We're really happy that they are here today. MR prostate diagnosis is becoming more and more familiar and implemented in daily clinical care. But of course, we get a lot of questions. How do you implement that? How do you select your patients? Where do you start when you do first an MR, then the biopsies? And do you do in-bore biopsies or fusion biopsies? And we're really happy that we have two great speakers today to give you an overview of this and how you can implement MR diagnostic track into your own clinical practice. So to start with that, I first want to quickly give you 2 slides introduction of Soteria Medical. So we are a company located in the Netherlands, and we developed a robotic device which can be used for MR-guided prostate biopsies. So based on the MR, we can do a targeted biopsy, really what we see based on our images. We are a spin-off company actually of the Radboud UMC. Jelle Barends has been supporting us from the beginning and had one of the first ideas as well. And in-bore MR biopsies has been known for a long time, but always has been known as a very expensive, difficult procedure. And the idea of our device actually to make it affordable for everyone, able to put it into daily clinical practice in a fast and easy way. And for that, you see as well how the patient is positioned, and we can do a targeted biopsy based on what we see on the MR images. The system is, as I said, completely MR compatible. I think during the talk you will learn much more about it from our clinical partners. It can be used in every MR suite and has the highest accuracy and the most accurate way of doing biopsies at this moment available. I don't want to go into much detail on this as of yet. Currently, the system is installed all over Europe, and even though through the pandemic we have started our first installation last year in the Mayo Clinic in the USA, and we're of course happy to get started in many of the other countries which we are not located in yet. Yeah, we're really happy that we achieved this in the last few years already. During this webinar, we give you mainly the clinical background and how to implement it MR biopsies. But if you are more interested later on in the system itself, I have it next to me here as well. We give new demonstrations going more into the technical details, how to implement it this Thursday as well as next Wednesday. On our website, you can register for this webinars as well. But for now, what we want to start off is, of course, how do we implement MR prostate cancer diagnostic trajectory? And therefore, we have two great speakers. They have many years of experience. They've done a lot of interesting talks at different international conferences. And both they also organize different teaching courses, which I really highly recommend to attend as well. If you are interested, please let us know and we can provide you with more information. Professor Jelle Barends will start with talk about the early detection of prostate cancer with PSA and MRI, starting from imaging acquisition towards biopsies. Go over that, give you an introduction to go over that whole trajectory. After that, we have a talk by Professor Kai Villanova. He will go more into detail how to implement in-bore MR-guided biopsies on the current diagnosis of prostate cancer. During those talks, please send in all your questions using the Q&A button below the screen. We already collected a lot of questions which came in up front as well. And after both talks, we will have all the time to answer those questions for you as well. After this short introduction, I want to give the talk to Professor Jelle Barends. Jelle, the floor is yours.
Thank you. Okay, well, thank you for this nice introduction. My talk is a little bit different from the previous talks you may have heard from me. I more want to zoom in to from MRI to biopsy, and I will tell you in a few minutes why. So let's continue. See whether this works. Uh, my conflicts of interest are I'm an advisor of this nice company and also of SPL Medical, a company that's producing ferrochrome syndrome. So acquisition is important. We should make good images, and this is the topic of another talk. Also, we should focus on reading, and this is Pirates version 2, and you can read a lot about it in many webinars. But then after you've had a good image, and if you do the interpretation well, you have to do targeted biopsy. Okay, a targeted biopsy or MR directed biopsy. And I will talk about it. If you want to read more about it, what the components are, I would like to draw your attention to this paper in European Urology. It's part 3. Part 1 is on acquisition, 2 is on diagnosis, and 3 is on targeted biopsy. It's of our group with our experts. Now, why is my talk today more focused towards MR directed biopsy? Because I think at this moment, biopsy is the weakest part of the chain that needs a lot of attention. And, and first there is a battle. How should we do it? In-bore MR directed biopsy. And Dr. Villanova will tell a lot about it. Fusion biopsy, cognitive biopsy. So there are all our various techniques. And well, what should we do? And the first question, which is appearing from the clinical field, is should we stick in more than the targeted needle? MR directed biopsy versus MR directed biopsy plus additional thrust needles. And that is a big question. And I will try to give a few answers based on a literature review that I did in the past few weeks. But first, where do we target for? What should be the target? Well, interesting question. Is it T2? Is it diffusion? Is it DCE? Well, let's have a look at this patient. You see a T2 weighted image and you see a diffusion abnormality over here. It's black, a black hole. So this is bad. The patient has an elevated PSA and already 4 times negative thrust biopsies. So this was rather unsuccessful. Now, an MR directed biopsy was performed, an in-bore biopsy, and it yielded a Gleason 4+3. Okay, now patient had a subsequent prostatectomy, and then you see that there was a larger tumor. And the question is why is that? Why is this tumor so large? I hope that some of you already have a clue. What's the explanation? And what is this actually? What's going on? Well, this is a Gleason 3 component, which is surrounding the Gleason 4 component. So please remember, you should point your needle at the most abnormal Gleason 4 area. So this is a patient, and here you see the diffusion weighted image. So don't target for the T2 because you may hit a 3+3 or inflammation, and with DCE it's even worse. Target for the most aggressive part. And what's the most aggressive part? The most aggressive part is the lowest ADC area, which is usual going together with the brightest area of a high B value image. And if you go to the calculated B5000 image, you see a small area over here. And this is the area where we were hitting our needle, and biopsy resulted in a Gleason grade 4, an aggressive cancer. So hit the most abnormal diffusion area. Second question, extra cores. Should we use extra cores? Do we miss significant cancer? Well, after a positive MRI, you may have no significant cancer in your biopsy due to sampling errors. And what you also see is that in an area which is adjacent to the MR target, so this red area, this is the target, adjacent to this area, there may be cancer. However, a systematic sampling of the entire region here, of the normal appearing prostate tissue, although the urologist likes to do it, is not good. It doesn't help. I will show you that based on literature later. The best way not to miss a significant cancer is to do focal saturation around the target on the MRI. This increases the yield of significant cancer without affecting the yield of insignificant cancer. You don't want to have too many insignificant cancers going along with more needles. That doesn't happen. Now, what is the optimal number of cores? There's a lot of literature coming out in the past few years, and actually there is some consensus that you should hit the target with first, so fusion biopsy with 4 to 5 cores. This is the nice paper of Liu et al, and you can see that if you have more than 5 cores, so going to 6, you can see that the yield of significant cancer isn't higher. So the best you can get is with around 4 needles, 96 and 94% of cancers detected, which are significant. And if you stick more needles, it doesn't really help. However, there is a nice a review editorial comment recently appeared in European Urology, which said, well, if you stick in 5 extra needles adjacent to the targets, you have an extra yield of 9% of significant cancer at the cost of 4% of insignificant cancer. And well, this is what Dr. Villanova probably will address also. For inbore, luckily you can reduce the number of cores. It is actually for inbore 4, and for the robot controlled or remote controlled manipulator, it is 3, only 3 needles. Well, of course, in large lesions, you need fewer cores. You need more cores for diffuse heterogeneous lesions or lesions which are located at difficult areas, anterior apex, or when there is a pyrite 3 or small pyrite 4 lesions or larger glands. So you need fewer cores for larger lesions, but more cores in the others. Now, what about the addition of extra cores to transperineal biopsy, because urologists are trying to stay away from the rectum? Well, if you choose for the strategy of 2 MR-directed targeted biopsies, plus 2 adjacent, plus 10 to 20 on the neighboring sectors, depending on the size of the prostate, you see that the yield of significant cancer extra is 25%. However, for large lesions, you can just do only 2 plus 4. Also, random and contralateral biopsies are not beneficial. Actually, they increase the number of insignificant cancers. So don't do that. This is a nice publication of Hansen in the British Journal of Urology Internal. Now, to learn MR-directed biopsy is not easy, and it is not MR that is wrong, so not the diagnosis, but usually it is the sampling errors that are the false negatives from results. In Porconi, it was 67%. And in our 4M study, you can see that if you, here, this is the pirates 1 and 2, pirate 3 and 5, we performed in all MR-targeted biopsy as well as thrust biopsy. Now let's zoom into these two groups. So the group of MR targeted biopsy only, 3 cores per lesion in bore, and this is MR plus TRUS. And you can see that there is an extra 7% of clinically significant cancers if you stick in 12 needles in addition to the core, at the cost of 2% in significant cancers. But there's something which is very interesting, is that 95% of the Gleason 4 components that we found instead of a 3+3, for example, a 3+4. So the significant cancer detected by extra cores was actually in 95% in 20 of the 21 patients in the neighboring areas. And the average number of cores that was needed was only 4. So the strategy of 3+4 is a good one. The other thing was, what is interesting is that they were all a Gleason grade of 2 and not higher. So it was actually a little bit of a 4 component that you detected with an extra needle, and not a 4+3 or a 4+4. So no very aggressive tumors. Now, if you summarize this a bit, then about 14 to 18 men need to have a combined biopsy with extra needles to detect 1 significant cancer more, at the cost of quite some insignificant cancers. So too many needles is not good. Now, this is a topic a little bit also of the next speaker. I will just address you and show you our experience. How do we perform? In our MDT, we discuss what technique we are using. So the lesion is being diagnosed, Pirates 4 or Pirates 5. Then we look at the lesion together, and then we decide, well, which patient is going to have a fusion biopsy and which patient is going to have an in-bore biopsy. Now, when do we use an in-bore biopsy? A difficult location, anterior apex or cranial. This is the paper of Martijn Schouten, and you can see the blue area is the area where the MR-guided biopsy is very advantageous in respect to the red area, which is the area where MR-guided biopsy in bore is not that good, but this is the advantage over thrust biopsy. Thrust biopsy is missing this area, and this is so anterior apex, but also at the base. And of course, small lesions, and we define lesions with a size of less than 10 millimeters as being small. Now, if you look at a paper of Wigelin and Arsov, then you see that in-bore and MR thrust fusion are better compared to cognitive biopsy, and that the detection rate of in-bore and fusion biopsy in large lesions is similar. Now, this is a case. You can see over here a T2 IB value image. Then you see over here the ADC map, and then you see the DCE, and you can see a tiny area. And what's the pirate score? Well, the pirate score is a 4. It's black and white 4, and it's a plus, so this is a pirate 4. A small lesion anteriorly located, and this was successfully biopsied with in-bore, and it yielded a Gleason 4+5, so a quite aggressive tumor, which was confirmed with histopathology. And as you can see, the other tumors with a lower Gleason grade, they are not detected. So you only see with MR, if you use the fusion, the most aggressive part. And you can see that there was even a 4+5 component. When do we also use in-bore biopsy? If we have a previous negative fusion biopsy in the Pirates 4 and 5 patient. So whenever you have a negative biopsy, and this is general advice, negative for clinically significant cancer, then you should ask, is the technique I'm using correct? Is the image good? Is the image of good quality? Second, is my interpretation okay? Third, is there a sampling error? And well, this is what you need to do then. That if you have a negative biopsy, with fusion, or even an in-bore negative biopsy repeated. Okay, now in large lesions, of course, it's plus. In-bore versus fusion biopsy. It was a group of patients where we pooled the data. Also, it was part of our data. And you can see that if you look at pirates of 3 and more and negative fusion biopsy patients with 2 to 3 cores per lesion with in-bore, you see that there is a 25%, so 1 out of 5, you detect a significant cancer. This is quite high. So this actually argues for the validity of an in-bore biopsy technique. This is 1 year after our introduction of MRI first, do not harm. So, inclusion, patient with elevated PSA. In pirates 1 and 2, no biopsy. In pirates 3, only 3 had a biopsy, patient with a high PSA density. And this is the interesting group, pirates 4 and 5, 128 patients, and they all had a biopsy. And let's zoom in on these patients. So 60 patients had an in-bore biopsy and 68 had a truss fusion biopsy. You can see that we had a little bit more fusion biopsies because of the size of the tumor. And you can see the distribution of pirates. You can see that with fusion, there are more pirates pies because of the fact that we choose for this technique in larger lesions. So these are the more difficult lesions. And now let's have a look at the results. If we draw the line of significant and insignificant in between a large Gleason 1 and a small Gleason 1, you can see that there are about similar results of clinically significant cancers of both techniques. However, the lesions here with in-bore biopsy were smaller. Now, this is an example. This is transfusion biopsy. This is MR in-bore rebiopsy. And let's zoom into one patient. He had a Gleason score of trust of 3+3. And actually, in-bore showed in 3 cores 3+4. This was the patient. It is a lesion over here, anterior. This is erased charcoal. It's at the apex, the anterior apex, erased charcoal. Also over here. There is confluent enhancement, so not popcorn, but confluent enhancement. You also see black and white on B1400 and ADC. So this is a 4, a 4, a plus, and a 4. Perhaps it's even a 5 because of its size. This was targeted with in-bore, and actually it yielded an aggressive cancer. So my conclusions is, first, you need to have a good MRI. So image quality, look at it. It should be good. And we are working internationally on a PyQual, a classification to look at the image quality. Second, do be a good PIRATS reader. So have your diagnosis being correct. Then third, if you pick up the needle, target for the lowest ADC, which is equal to the brightest B1400 or higher on the image, because that is the most aggressive part. And that's what we did over here. Use 4 to 5 cores, but also focal saturation with 5 extra needles when you have less experience. So when you start, stick in a few more needles. Actually, because we have experience, we are using now 2 to 3 needles per lesion. And also, if you have a small lesion or a large prostate or a difficult area, of course, perform focal saturation. But it is not necessary, based on literature, to just puncture the prostate with 20 truss needles. And that's what the urologists currently are doing in a patient with a positive MRI in about 50% of cases. So I think that this is more or less the message that I have. And of course, if you now are motivated to start to do in-bore biopsy with a remote controlled manipulator. There's no better person than Professor Kai Villanova, who has an extensive experience with this technique, and he is going to show you how you are going to use this nice tool. In the end, the patient will end up with only 2 calls per lesion, and that's good. Highly representative. So thank you, Martijn, for the opportunity to give this lecture. I hope you don't mind that I didn't talk about early detection, but well, biopsy is a very important part of early detection, and I think we should look on the quality of biopsy, because well, many urologists think that it is easy and you can do it, but what I see is even in well renowned centers, even in our center, I sometimes see quite some unexpected biopsy failures, and we should try to reduce it. Thank you for your attention.
Thank you very much, Jelle, for this very interesting talk and overview. I think there's nothing much I can add to that. We will collect all the questions. We have already some questions coming in, so please fill them in and we will answer those after the second talk of today, Kai Villanova. I'm very happy that you're here today as well to tell about your experience. I think, are you still on mute, Kai?
Yes, well, thank you very much. And first of all, I want to thank Soteria for organizing this meeting. And as it is scheduled, my talk will be dedicated to this inborn guided biopsies. So just an introduction, and I will just, but already Dr. Barents has shown us what are the different procedures that we might reach a target biopsy. But of course, I'm going to focus on inborn and how to implement this inborn technique. We already know, Dr. Barents has already shown that for today, we know that the procedure to diagnose a prostate cancer is to have an optimal MRI. Once we have read an optimal MRI and whether we have a suspicious lesion, PIRATS 4, PIRATS 5, then the target should be within this lesion. And of course, as we have seen, significant cancer will be detected. We are going to avoid to detect the non-significant cancer. And with these target biopsies, we are going to avoid biopsies. We are going to, as we have seen in the previous lecture, less course, less complications, more significant cancer diagnosis, less insignificant cancer diagnosis. We know also the recommendation for now is very clear. We have to perform target biopsies, still not recommended to avoid these systematic biopsies with naive patients, but I'm sure the prostate in the near future will have the same as any organ in our body. The prostate is the unique organ that to reach a cancer has to perform a biopsy from the whole organ, but time will have to show the proper just biopsy from the lesion, as it is the recommendation from the patients that had a prior negative biopsy to have only target biopsy. We have seen and we have 3 different procedures that we can reach a lesion. I'm going to show in inborn MRI to target this lesion. We know that from the ultrasound, either cognitive or using a software. The 3 systems have different characteristics. Inborn MRI, we have and we see the lesion within the MRI. We have the real feedback of where is the guide, where is the needle within the lesion, as we are going to see. Dr. Barents has already said, and I'm going to show that inborn can and is detecting these small lesions using a robotic approach. And of course, as that this is a technical issues, things have to be learned. This is similar as any software that we use in our daily practice, and even whether we install a new software in our computer or in our mobile phone, we have to learn. So this is similar, and I'm going to show you that within 1 week, you are ready to perform an inborn MRI biopsy of prostate cancer to detect the prostate cancer. We don't need any anesthesia. We don't need any other additional professional, because just a radiologist, it is enough to perform this procedure with, of course, as I'm going to show, with the rest of the team that allows us to implement this procedure. Of course, this is a higher cost than without any software, but sometimes higher cost at the end could be less cost if we reach with better accuracy just with 1 needle or just 2 or 3 needles, instead to performing 2, 3 different procedures, as we're going to see on several examples. We don't need any registration because already the MRI is there. We just perform a target biopsy because this is what it will be. Of course, we have the future just to target the biopsy. And of course, not available widely, but this is similar as the procedure to the surgeon, that a surgery is being performed with a robotic device. So why not we don't have to be performed the biopsy with a robotic device? If surgeons have a robotic device to precisely operate the prostate, then we can and we should be allowed to have also a robotic to diagnose. The team from Dr. Barnes has already shown that if we have the question, what is the better system? Well, it depends mainly on the experience, because if you have enough experience, you can have the accuracy either using cognitive, either using fusion, and using inborn target biopsy. We have seen from the previous lecture how important it is to know and to read where is the suspicious lesion. And we know that the key, and we have seen in the conclusion from Dr. Barnes, the key to diagnose a significant cancer is diffusion and ADC. Because diffusion and ADC is the dominant sequence in the peripheral zone lesions. But also we know from the new version how important also is diffusion in the transition zone. So this patient had already had 12 needles in the prostate. PSA rising. This patient has a small prostate because 10 years ago had already an adenomectomy. The T2 shows asymmetry, but the diffusion is very clear. Then whether we see where I have to place the target, and in this case, combining with the ADC, black and white, I need a needle here. Then I plan the target, the robotic is movement, and I just take 2, 3 samples, and the 2 and 3 samples Gleason 4+3. So how I'm going to perform this procedure? Any special field strength, any special coil, any specific protocol, and of course, the device that I'm going to use. No specific field strength, the same that you have been performed the diagnosis. Of course, if you have a 3 Tesla for diagnosis, you are going to use a 3 Tesla for biopsy. If you are going to diagnose or you have a 1.5 Tesla, still I have a 1.5 Tesla, I'm using 1.5 Tesla for the biopsy. No specific coils. You are going to use the same as diagnosis because you can see better, but it's not also so specific to have very high number of channels, because this is just, you know already where is the lesion, just you have to localize. So even no very high channels are necessary in order to localize this specific. A specific protocol, but mandatory, of course, the key sequences that we know from diagnosis are going to be key in location. And then a specific sequence to just manage and confirm that the guide is in the lesion. And this is fast sequences. And you are going to use balanced sequences, 20 seconds acquisitions to confirm that the guide has moved to the target. So Martin has already said that different devices in the last decade were developed. At the beginning, of course, quite difficult to manage because all were manual. Even the different later the devices that were already manual that you have to adjust manually. And with these manual devices, the detection rates were as high as 60%. So now we have seen that we can have a robotic automatic device that is just remotely, not manually adjusted. This device is adjusted to a guide and the guide to the rectum of the patient. The patient goes within the inboard and remotely connected to the software. Once the patient is acquisition the sequences, because this patient had already 2 previous biopsies, again, 20 needles. This patient had already a positive MRI, but a PIRATS 5 with a negative transrectal ultrasound cognitive biopsy. Now I have the patient and I'm going to plan to place the needle not strictly on the T2, because I have to check the diffusion and I have to place a needle here. Because if a needle is placing somewhere like here, already low signal intensity, it might turn as this patient had already 20 needles. Then I'm planning. The robotic is going to move the guide through this position. Once I know with these fast acquisitions, I'm going to enter in the room and knowing that I have to leave 3 centimeters because this is the distance that the robot is showing me after moving the robot. I'm taking just 2 samples and the diagnosis after 20 negative needles, a Gleason significant cancer. So this is how any procedure on MRI requires 3 ingredients. And this has to be managed by the radiologist. First, the MRI equipment, very important, the technical application from the vendor. Then the radiographer, the technician that is going to perform this examination. And of course, the patient. These are the 3 ingredients that for any procedure, any MRI. But here we have additional the device. So very important, the technical engineer that is going to support on all this implementation. And finally, because this has to be connected, the device with the MRI, then the IT department. So once we have all this team conjoined, now it's time for the training. The first day, we are going to learn how to set up the system. And also how to train and the software, how works this software, this new software that I'm going to adjust and to target the lesions. So on the 3rd day, we are allowed to perform the biopsies, but of course in phantoms. But on the 4th day, we are already to perform the first biopsies, the real biopsies with these patients. And even the next week, you are allowed to perform by yourself, as I did, just the biopsy. But of course, nowadays, we have already the support live from the engineer from the device. And of course, after several weeks, we are going to have an on-site again from the technical engineer second training to gain experience and to know different tips and tricks that are going to be important to localize a specific difficult locations as we're going to. Because whether I know previously, because I know previously where I have to reach, whether lesions are in the base, before providing the guide, I will place a pillow below the patients because already the rectum will go towards and it will be much easier to reach the target on the base. Or lesions that are very lateral, once the guide is going to move, they might touch the rectum or the buttocks. So then, just remotely, I will remove some 1 centimeter, and then the robot I will provide to move laterally to reach the target. Or whether the 6 millimeters lesion, very lateral, before I'm going to study and I will place and I will leave the contrary side of the patient. So in this case, the left side of the patient, because this is the right side lesion, 6 millimeters, very lateral. So I'm going to target again diffusion. You can see not seen on T2, very nice, high signal, white and black. This is the ADC. I'm going to target in this specific. Once the needle is moving with the guide, I'm just taking the sample and for a significant cancer. We have seen in the manual systems as high as 60%. After 8 months using, my first 30 biopsies were reported some months ago, and now after 17 months, 50 biopsies with detection rate of cancer 74, significant cancer 92%. These are the results. But one might ask, using this device, this might occupy my MRI. Very busy. We know how busy is an MRI nowadays. This is going to interfere on my department. Well, I'm going to show you no more than 30 minutes. This is not going to interfere in any scheduled routine MRI. Of course, the first 10 biopsies, I scheduled 60 minutes occupation, but now 45 minutes. This is the schedule from last week, last Monday, not yesterday, last Monday. I performed 2 biopsies. You can see, this is the morning slot. I had the 9:15, the first biopsy. Previous to 10, I finished my first biopsy and I started the second. The second biopsy was an anterior. This was a Pirate 3, not very suspicious, but we had the target biopsy. And you can see that before 10:30, I already had the guided here. So before 10:30, I finished my 2 biopsies. This was just a routine. MSK and even brain, and this is hip, knee, this is wrist, brain. So a routine. Just I was performing 2 biopsies and no interference with the schedule. So as for today, we know diagnosis of prostate cancer is target biopsies, whether there is a suspicious on MRI. This is the procedure that we have to perform. Then we have to be precise. We can choose, we have different options, ultrasound, MRI. If we are using MRI, we know that we can provide a very automatic robotic system. That it's not very, I have shown my experience, 1 week, I perform the first biopsy. And we know and we see the suspicious lesion on diffusion and ADC. Then the system, the guide goes where the diffusion has significant suspicious. Then much accurate detection of clinical significant cancer. And of course, this might improve our management of prostate cancer. And as I have shown, no interference. So this can be done in our routine workflow on any MRI schedule. And this was what I wanted to show.
Really would like to thank both Professor Villanova as well as Professor Barends for their support and very interesting talks. And have a great and safe evening.